All right. Today, we are diving into one of the most high stakes situations you can face in medicine, a patient with markedly elevated blood pressure. This is a scenario that really demands a cool head, a super clear plan, and some very precise action. So let's get right into it.
Okay, so picture this. A patient's blood pressure pops up on the monitor, 220 over 130. Your first instinct, naturally, might be to panic a little. But is that number by itself an automatic emergency? Well, the answer, and this might surprise you, is it depends. And that's the big question we're here to answer today. So we're going to walk through this with a straightforward 5-part clinical pathway. First up, we'll define what actually makes this a crisis. Then we'll get into the evaluation and workup, the principles for managing it safely, some very specific treatment goals, and finally, how we get the patient from that crisis moment to solid, long-term care. Let's kick things off with Section 1, Defining the Crisis. The key takeaway here, and it's a big one, is that the scary number on the monitor, it doesn't even begin to tell you the whole story. So officially, when we say markedly elevated blood pressure, we're talking about a systolic over 180 or a diastolic over 110 to 120. Now, I want you to think of this number as a fire alarm. It's loud, it definitely gets your attention, and it's telling you, hey, you need to investigate this, and you need to do it right now. And this right here, this is the single most important decision you're going to make. Is there an actual fire, or is it just a blaring alarm? See, a hypertensive emergency is defined by one thing and one thing only: new or worsening end organ damage. That means the brain, the heart, the kidneys, they are actively being harmed as we speak. On the flip side, asymptomatic elevated blood pressure is just that high number without any evidence of that acute damage. And let me tell you, this one distinction changes absolutely everything. So to quickly recap our first section, a blood pressure over 180/120 is your trigger. It's your call to action. The absolute key question you have to answer is there end organ damage? Because the answer to that question is what determines the entire road ahead, whether you're looking at an ICU admission with IV drips or a situation that can be managed much more slowly. Okay, let's move on. Now that we know exactly what we're looking for, how do we actually find it? Welcome to Section 2, which is all about the clinical detective work. Your whole investigation kicks off right there at the bedside with a really systematic 4-step evaluation. First, you get a targeted history. Are they having chest pain, trouble breathing, weird visual changes, any new weakness? Next, a focused physical exam. You're listening to the heart and lungs, checking pulses, doing a good neuroexam. Third, and you can't skip this, a fundoscopic exam. And fourth, you're ordering those first initial tests to look for any hidden damage. And this slide right here shows you exactly why that fundoscopic exam is so critical. This isn't just some abstract concept. It's a direct window into what's happening to the body's smallest blood vessels. What you are looking at is papilledema. See the swelling of the optic nerve, the little hemorrhages? This is stone-cold, objective proof of severe, acute end organ damage. If you see this, you know without a doubt you are dealing with a true emergency. Okay, so beyond the physical exam, these are your go-to tests. An ECG can pick up on heart strain or ischemia. Simple labs like a metabolic panel will tell you about acute kidney injury. A troponin is going to look for any damage to the heart muscle. And of course, if your patient has specific symptoms like they're short of breath or have a new neurodeficit, then you've got to get targeted imaging like a chest X-ray or a head CT. So let's wrap up our evaluation section. It's simple, really. Everything you do, every single question, every exam move, every test you order, it all has one single goal: find or definitively rule out acute end organ damage. That's it. And I'll say it again. Looking in the back of the eye with that fundoscope, absolutely non-negotiable. All right, so you've done your detective work, you've made the diagnosis, it's a true emergency. Now what? Let's move to Section 3, the principles of safe management. And the theme here is critical. We want control, not chaos. This quote right here is the golden rule. You need to burn this into your brain. In almost all hypertensive emergencies, your goal is not to slam the blood pressure back down to normal. The goal is a controlled, deliberate reduction of no more than 25% in that first hour. I promise you, going too fast can be just as bad as the high pressure itself. But why? Why do we have to go slow? Well, it's all because of this fascinating process called cerebral autoregulation. See, in someone who's had high blood pressure for years, their brain has adapted. It has literally reset its thermostat and now needs that higher pressure to get enough blood and oxygen.
So if you just come in and yank the pressure down too quickly, you can actually starve the brain of blood and cause an ischemic stroke. The analogy here is perfect. Think of it as a controlled demolition, not just blowing up the building. This table just lays out those two different pathways crystal clear. For an emergency, the patient is going to an ICU. For an asymptomatic case, maybe they're just observed or managed as an outpatient. An emergency demands continuous monitoring with an arterial line, while the other just needs intermittent cuff checks. For an emergency, we're using powerful, titratable IV drugs. For the asymptomatic patient, we're just using simple oral meds. And the goal? A controlled 25% drop for the emergency versus a slow, gradual reduction over days or even weeks for the other. So the bottom line from this section is that safety is everything. A slow, gradual reduction is how we prevent causing more harm, especially to the brain. And that initial diagnosis, emergency versus non-emergency, that's what dictates the entire plan, from the ICU bed to the IV pole.
All right, now we get to the really interesting stuff, the nuances. Not all emergencies are created equal. Section 4 is what I like to call the specialized playbook, where we tailor the treatment to the specific organ that's taking the hit. Man, this table is so high yield. Just look at the exceptions to our go slow rule. If you have an aortic dissection, that rule goes out the window. You have to be incredibly aggressive and drop that systolic BP below 120 fast, within 20 minutes. And the clinical pearl is life-saving. You have to give a beta blocker to control the heart rate before you give a vasodilator. Then you have things like ischemic stroke, where we actually allow for permissive hypertension sometimes. Each condition has its own unique goals and its own preferred drugs. And here are the tools of the trade, the workhorses. Nicardipine and labetalol are your all-stars, great for a lot of different situations. Esmolol is a specialist. Its super short half-life makes it perfect for something like an aortic dissection, where you need precise minute-to-minute control of the heart rate. And nitroglycerin, well, it's the king when the heart is the problem, since it's so good at reducing the heart's workload. So the big takeaway from our specialized playbook is this: treatment is absolutely not one-size-fits-all. Once you know which organ is in trouble, your treatment becomes highly specific. That go slow rule has some really important exceptions. The target organ dictates everything: the target blood pressure and the tool you're going to use to get there. And finally, let's talk about the handoff. Let's look at the transition of care in our fifth and final section. The immediate fire is out, but our job is far from over. It's time to move from crisis management to long-term control. Look, a safe discharge doesn't just happen. It's an active process, and this checklist is your roadmap. You've got to make sure they're on the right oral meds, usually at least 2 different ones. This one's huge. Book their follow-up appointment before they even walk out the door. Give them crystal clear instructions on red flag symptoms, and then communicate everything that happened clearly to their primary care team. And you know, the pills are only one part of the equation. Real long-term control is built on a foundation of lifestyle. We have to counsel them on a low-sodium diet, on weight management, on getting more active, and on limiting alcohol. And we have to empower them by teaching them how to monitor their own blood pressure at home. This is how we stop the next crisis before it even starts. And now that really brings us to our final thought here. You know, managing the acute crisis, that's a technical skill. It's something you can learn from a book. But the real art of medicine, it's what comes next. How do you actually build a partnership with your patient to make sure this never, ever happens again? That's the question that truly defines great long-term care. Thanks so much for joining me.